Welcome to Doc Discussions with Dr. Jason Edwards, brought to you by St. Luke's, St. Louis.
Hello, this is Jason Edwards with Doc Discussions, and I'm here with Dr. Patrick Yeung. Patrick, how you doing today, sir?
Great. Thanks so much for having me.
You bet. Now, Patrick, you're an OB-GYN, is that right?
Yes, sir.
But you specialize in a very niche field. Can you tell us about that?
Yes. No, thank you. I always say I'm a slow learner, but hopefully when I get it, I get it. I did 2 residencies and 2 fellowships to do what I do.
Which residencies and fellowships did you do?
I did family practice first.
Okay.
At St. John's Mercy, it was called at the time.
Yeah.
And now it's, Mercy. And then OBGYN, and then a fellowship in minimally invasive gynecologic surgery, and then a mini fellowship or an extra fellowship to learn to use the laser. We can talk about that, but that is my cutting tool of choice. It's a very precise, non-contact cutting tool. To be able to treat endometriosis, that is what I treat. So I have what's called a Restore Center for Endometriosis. We talk about offering a root cause treatment to remove this disease. Most people just burn it, for lack of a better word. They're trying to destroy the tissue or the implants with energy, but they don't remove it. By removing it, we're showing great outcomes that are better than or different from the usual or status quo treatments for pain or for fertility, which are really Band-Aid therapy or bypass therapy.
I'm gonna back up just a touch. So you did your training at Duke, is that right?
I was there for 3 years. My first real job, I say, yes.
And then you ran their endometriosis center, is that right?
I began a center for endo at Duke.
Very good. And then I'm going to go back and endometriosis. Now I'm going to give my definition and you tell me if I'm right or wrong.
And then SLU after that. So St. Louis University, began a center there. I was there for 10 years.
Very good.
Now private practice.
Here at St. Luke's. And you and Don Summers work closely together. Is that right?
Yeah, I have an independent practice, but we operate here at St. Luke's for mostly the deep endo or advanced endo cases that can involve the bowel, sometimes a bowel resection. Those are done with Dr. Summers, who's here, yes.
So my understanding is, you have this, the lining of the uterus, it's this thin layer of cells called the endometrium, and they slough off and go out of the fallopian tubes and into the pelvis and grow into these sometimes masses that cause trouble with the anatomy and inflammation in the pelvis. Is that?
Okay, so a 2-word definition is ectopic endometrium.
Okay.
Which means cells that are normally in the lining shed during the period found in the wrong place, outside the uterus. So now, how do they get there is the question. So again, they're by definition outside the uterus. The number 1 symptom is pain with periods. It can affect or cause pain and infertility. The number 1 theory of how they get outside the uterus is this backflow theory that you described, or the retrograde menstruation theory of Samson, which is when a woman is having her period, she bleeds backwards through the tubes and those cells implant. That is still the most common and traditional theory, but there's a lot of problems with the theory. Like endo has been found before the very first period, after the last period outside the pelvis, lungs, brain, back of the eye, in men, places where backflow cannot reach. And it leads to a lot of endo myths, things that aren't true. Like if you take out the uterus, you're going to take out the source of endo based upon the backflow theory, so that you cannot have endo without a uterus. That is 100% not true, especially if you've left the ovaries, which can stimulate the endo, again, which is by definition outside the uterus. You've done nothing to the endo if you just remove the uterus. Or they're going to say, well, if you can stop the periods, that's going to turn off the tap, stop the source, and so you can't have endo after having no periods for a long time. Also 100% not true. People have said that the number 1 thing we can do to really help women with endo is to get rid of the bad theory, because it leads to endomyths. So modern day theories include stem cells, metaplasia, the cells just change, and maybe at a particular window in a woman's development, so it doesn't keep happening. It's not an ongoing process, so then if you can cut out the endo and do that well, you can have great outcomes, which is what we're showing.
Yeah, I got you. And so, and like everything in science and medicine, it's always way more complicated
That's right.
than you think. And so that's fascinating to hear kind of the competing theories, right? And hopefully in time we learn more and more about it.
Yes.
And so what you do, which is very unique, and there's only a few doctors like you in the country, is my understanding. You go in with your CO2 laser and remove these pockets of ectopic endometrium that are in the pelvis that are causing pain or changing the anatomy of the uterus and the fallopian tubes and the ovaries, causing infertility. And sometimes these are really tedious, meticulous surgeries that last a long time.
Right. So this disease starts off on the surface. As the disease progresses, it can go deeper. You can get a ball of it in the ovary called a chocolate cyst or endometrioma. You can get a ball of it in the bowel or the bowel wall called a bowel nodule that can make things stick. In fact, the disease can make all the anatomy stick. So in advanced cases, you can get what's called a frozen pelvis, where uterus, bowel, tubes, and ovaries are all stuck together. So I like to start by saying there's a TED Talk called The Most Common Disease You've Never Heard of. I love that title. That's endo. Everybody knows somebody with endo. And the common phrase out there or thinking is, it's 1 in 10, hashtag it. That's the rate of endo. But it's much more than that. Okay, the two main things that endo is associated with or causes is pain and infertility. So if you have infertility, no pain, it's at least 50%. Pain that does not feel better with hormonal suppression or birth control pills, it's over 80%. Pain and infertility, it's over 90%. So it's so common. Everybody knows somebody with endo. The usual treatments, the status quo, I like to call it, is Band-Aid therapy for pain, hormonal suppression of some kind, whether it be chemical pregnancy with birth control pills or chemical menopause or all the newer medications for pain. Bypass therapy for fertility, I call it, like IVF. Bypass the problem, make a baby in a test tube. Or this idea that you're going to have surgery every couple of years for the rest of your life. That status quo, that usual treatment is not satisfactory to most women. At Restore Center for Endo, our approach is to remove the actual disease. We call that root cause treatment. Remove the disease to avoid the need for long-term suppression, basically because it's gone, to lead to natural fertility and hopefully recurring natural fertility, and for the hope of one and done surgery, which no one thinks is possible, but we're showing is possible. We just published our 10-year study from our experience at SLU, St. Louis University, and our rate of repeat surgery was very low. It was under 5% in 10 years. And even without most patients taking any long-term suppression post-op. The usual rates of repeat surgery after the burning, which is what most people do, is 50, 60, 80%.
That's great.
In 2 years. So again, we're showing a very low rate of repeat surgery. And so we're saying one and done surgery is possible. And we would say the way to get there, which should be the goal of all centers of endo, is to try to offer to patients one and done surgery. I think, surgeons have kind of given up. They're going to burn what they can, but if it's near a vital structure, they're going to put them on long-term suppression post-op. They don't have to remove it all. Or for fertility, they don't have to optimize the anatomy because they're just going to bypass the pelvis and refer to IVF, or just come back and do it again in 2 years. That's a very different surgical mindset versus trying to remove it all and optimize the anatomy now. And so I think that's a very different surgical mindset on behalf of the surgeon, but also we're showing, I think, a very different surgical result for the patient. And so we're trying to combine the best of cutting it all out, we call that optimal excision, and adhesion prevention. So very few cut it all out well, but the other half is to prevent adhesions. And that's how we would say you achieve such great results or achieve the goal of one and done surgery.
Yeah. And you use the CO2 laser to do the
So my cutting tool of choice, as you say, yes, is this free beam, non-contact CO2 laser. So I don't have to touch the tissue to cut the tissue. It's very precise. It's literally cutting one layer at a time. You can see the layers separate. And so there's not that kind of danger of pushing too far. People ask why I don't use the robot. I used to use the robot. I think, the robot doesn't have this type of laser.
Do you do your surgeries open or laparoscopic?
So they're all laparoscopic, minimally invasive.
Okay.
Less holes than a robot.
Yeah.
Less visible holes than the robot. The robot's only been shown to really, not improve outcomes, but only increase time and cost in benign surgery. So I don't use it for what I do. And especially surface endo or stage 1 to 3, I wouldn't use it. Now, stage 4, maybe.
Why is that?
Just because by then it's not really delicate surface endo, it's more just deep endo. And maybe the robot would be fine for that.
What are the side effects from the surgery, or potential side effects from the surgery?
So the main criticism of surgery or excision, cutting it out, is that you're going to create all these raw surfaces, which will promote adhesions. So it's going to make things worse for fertility.
That's a theory.
That's a theory that has not been shown to be true. Again, with our anatomy optimization and non-surgical optimizations for patients with fertility, when you treat the endo, they feel better and they have improved chances of fertility. And I think they actually go hand in hand. Feeling better and chances of pregnancy go hand in hand.
Yeah, for sure.
What are the rates of fertility? So the national average for IVF is 32%. When you're talking about root cause treatment and restorative reproductive medicine, or optimizing the anatomy and the non-surgical factors for fertility, the rates of pregnancy can be up to 70% in 1 to 2 years.
What, did you, in the study you guys did you guys measure that as an endpoint, fertility?
In the 10-year study?
Yeah.
Well, it was a database, and so we had different endpoints.
Gotcha.
But this one was focused on rates of repeat surgery.
Yeah.
But there are other studies, yes, that show up to 70% fertility rates, even in advanced endo.
Yeah.
So it's very effective. And again, patients are feeling better, and it can lead to recurring fertility. And if it's one and done surgery, it's very cost effective.
Yeah, for sure. Yeah. And there's it's a big picture. I mean, you're not only looking at fertility, you're not only looking at pain. It's obviously significant psychological benefits if you're not in pain, if you're not having to, continuing to have surgeries. And so, seems like a lot of positives on a lot of fronts.
Yeah. The real reason why, I began Restore Center of Endo was to enter the conversation among centers of endo to say that what we're doing is different, and here's how you can try to get to one and done surgery. But really, it's also to pay it forward. That is the real reason for Restore Center for Endo. So my wife had painful periods her whole life. We tried from day one to get pregnant. After a year of trying, she said, maybe I have endo. I said, no way. She had bad endo. She had one surgery to remove the endo and then multiple surgeries for adhesions. She's now pain-free, and we've had recurring fertility.
I saw your 5 beautiful kids on your website.
Praise God. Yes, thank you. So, but going through the journey with her, and again, we're trying to pay that forward, and in our story, preventing adhesions was as important as removing all the disease. But going through the journey with her, not knowing why somebody is not getting pregnant is as bad as not having a baby, or at least adds insult to injury.
Yeah.
To be told you have unexplained infertility, which, again, mainstream would say 30% of infertility is unexplained, is a slap in the face. A woman knows that her body is designed to get pregnant. And if you look hard enough, you will probably find an answer to why, or a factor that is, and often multiple factors, that are leading the woman to not be able to get pregnant. And many of those women have endo. So again, a normal ultrasound and a normal exam do not rule out surface endo.
Doc Discussions with Dr. Jason Edwards. Brought to you by St. Luke's, St. Louis.
Yeah, I mean, so I look at a lot of like scans and things like that, and I would assume that like a focus of endometriosis would have about the same Hounsfield units as like fluid or anything else, and so it would be kind of hard to see on a scan, I would think.
Well, if it's advanced endo, again, it's gone beyond the surface, and it's now a ball of it in the ovary. That's stage 3 endo. That's an endometrioma. If it's in the bowel, that's stage 4 endo. You can see advanced endo when there's some thickness to it.
And then it's deflecting other tissue and missshaping it.
But if it's just surface endo, stage 1 to 2, that's not going to be picked up on exam or imaging. But stage 1 to 2 endo or surface endo can still affect pain and fertility, and treating it will help both. So again, a lot of this unexplained infertility disappears when you actually look for and treat underlying conditions or root cause treatment. And again, having an answer, having that disease removed from your body is so important in the healing process of a woman who's not getting pregnant.
Yeah. And like you said, like a lot of diseases, it has a ripple effect, not only in the individual's life, but also, their spouse and, whatever it is, whether it's cancer, endometriosis or whatever. And so, well, that's great. It sounds like kind of an avant-garde, advanced technique and practice that you have here. And sometimes with that comes, if you're kind of pushing the status quo, sometimes you can get a little bit of headwinds.
Yes.
Is that the case with your practice or not so much?
Well, I would say it's really a return to trying to focus on treating the patient.
Yeah.
Again, this is not to bash on IVF. It has its role. But I would say it this way. The director of an IVF center asked me, who is the most important person in the IVF center? Okay, you get to guess.
Well, I mean, we're supposed to be patient first oriented, so you could say the patient.
Okay. Common answer, great answer. Well, first off to say, it's not the director of the clinic. Okay, it's not the person who got into med school.
We love our administrators, but...
That's right. Completed med school, did residency training, subspecialty fellowship training to become an REI, reproductive endocrinologist and infertility specialist.
Which is a difficult field to get into.
Right. And now owns and runs the IVF center. It's not that person. And it's not even the patient. She posed the question, she gave the answer, which is the most important person is the embryologist. It's the person that runs the lab because that's where the action is.
Okay.
So just to say, the woman is not being treated to help produce the baby. So women, this to me was just mind-blowing, or at least highlighted the point that, women want to be treated as patients. Women want to be healed to have the baby, and that's as important as having the baby. They want to be restored. So that this title, Restore Center for Endo,
it's a great title. It's a great title.
But again, having lived through it, there's a real desire there by women to get answers, to be restored as much as having the baby, or at least that's a very important part of the healing process.
Yeah.
Okay, so this issue is, I would say, an issue for our time. I really think this idea of restorative reproductive medicine as an alternative or as a way to try to get pregnant without bypassing the problem and really offering root cause treatment is really an issue that is a great moment in our society and that cuts across the political spectrum. People come at it from both sides, but people are wanting root cause treatment kind of to be more organic or natural, to lead to natural fertility.
Sure.
For a patient without big pharma, without just suppressive Band-Aid treatments or treatments that, end up with a lot of hormones in the environment.
Yeah.
Or that flood your body in a very artificial way, or bypass therapy with big fertility, we'll call it. And so I think there's a lot of grassroots movement or desire for options for fertility that are not just the usual.
Yeah. Yeah. And if it seems like if you have, very significant endometriosis, it's something that would probably give people hope. And I'm sure it's a gratifying field to be in, to see patients who may have kind of given up on things or maybe didn't want to take, a certain route and they come into your clinic and you get to see, them and their spouse and how it changes. I mean, is that right? Or can you talk about that?
Yeah, I love what I do. Again, I'm a slow learner and I went through all that, but I love what I do every day. And I steal my wife's phrase all the time, that to help a woman get her life back, get answers, or be a part of having a baby, I mean, it has eternal value. I love it.
Yeah, that's great. That's great. Well, how can patients, if they were interested in just kind of taking that first step and kind of looking into this, you have a website, is that right?
Yes. So it's called Restore Center for Endometriosis is the name of the practice. The website is restore-endo.com or restoreendo.com. There's a lot of information on there. But, so we're here in St. Louis. We're based here. There are very few centers in the country that are really focused on this type of root cause treatment and can do this type of surgery to restore the anatomy, especially for advanced endo. We can often take a team like we have here. Some places really do believe in cutting out the endo, but don't have a good bowel surgeon to work with. I feel so blessed to be able to work with Dr. Summers. We've been together now for 10 years. And
you guys have a reputation for being meticulous and and doing what it takes to get the job done, because these are not easy surgeries. I mean, for people who don't know, doing surgery in the pelvis is kind of like doing surgery in an upside down traffic cone. Like the deeper you get, the more narrow it is. And so this is a highly specialized treatment. And that's one of the great things about healthcare in St. Louis is you have these kind of super specialists that are available. And all the systems have, really great doctors. And so I always say with St. Luke's, we have incredible competition, because there's really good hospitals all around. But we're fortunate to have, something like this. And I know a lot of your patients fly in from other places to get their treatment.
Yeah, thank you. Now, we actually see more patients out of state than in state. Again, very few places can do this well. People come from all over. It's very humbling. But I hesitated there because I was going to say, so I learned, I hope it's okay to say, Don, but
speak freely.
Dr. Summers, when he graduated residency, I think it was, they roast you.
Yeah, sure.
So when he graduated, he got the OCD award, which when you're dealing with endo is exactly the guy you want. He is meticulous. And for these advanced endo cases that can involve the bowel where things can be stuck, might include a bowel resection, we allow all day. We do one case all day.
Yeah.
So we're not rushed. We can do what needs to be done. And St. Luke's has been so supportive in this. We've been here now for 4 years. In this effort to treat patients, patients love their experience at St. Luke's. Again, it wins awards all the time. But to have a place to operate that is supportive of these cases is so important, and we're so appreciative.
And what you mean by supportive of the cases is the cases are long cases because
they can take all day.
If you're doing whatever it takes to get the job done, it could be a 10-hour surgery if necessary. And the truth of it is that's a stress on the staff and it's a stress on the system. And so it makes a big difference to have that support.
Right. No, and St. Luke's, I think at first they weren't sure, to be fair, but they've seen over the years the outcomes for the patient first and foremost, and that, the patients do well, and it's really helping people. And so they've seen that. I would call our practice a mission-based practice. And I really think, St. Luke's is on mission together with us. And first and foremost, patients are benefiting. And again, their support has been wonderful.
Well, Patrick, we're fortunate to have you and Dr. Donald Summers on staff here or your practice here. And I want to thank you for not only the work you do, but I want to thank you for being here at St. Luke's. We appreciate you, and the website's restoreendo.com, and check it out and reach out to Dr. Yeung and his staff if you think he may be able to help you.
Thanks so much.
Thanks, Patrick.
Thank you.
Join us next time for Doc Discussions with Dr. Jason Edwards. It's medicine for your body, mind, and spirit.